everyone, and welcome to Childbirth. I am recording this lecture so that you can review this at your leisure. The information in this lecture is testable, and if you have any questions about this lecture, please don't hesitate to reach out. I wish we were in person though. I love this topic. All right, so the goals for the nurse taking care of a birthing person in labor is to promote comfort and also to support her and the family. Just up front, I know that some of my slides do not include inclusive language, and I'm going to have to go back and revise these slides. We need to remember that we take care of all different sorts of patients during our careers, and we want to make sure that we're using inclusive language so that we respect individuals. So I hope I don't offend anyone in my lecture today. That's definitely my intent. This is new territory or newer territory for me, and I'm learning. All right. So everybody listening to this lecture probably has heard that labor, there's some discomfort, some pain associated with labor, and it's generally a universal experience among birthing persons. However, it's very subjective. I've taken care of patients that denied having any pain or much pain, and then I've had patients that have complained of just very severe pain. Pain is highly subjective, and it's highly variable, and it's influenced by culture. We have cultures that are very stoic about their pain, and they will not admit to experiencing or perceiving pain. And then we have, on the other end of the spectrum, cultures that are very highly vocal about their pain experience. So whatever their culture is right for them. We shouldn't be judging individuals because pain is what the patient says it is. So during the labor experience, women have different perceptions of pain based on the stage of labor. And typically in the first stage of labor, and if you remember and watch the first lecture, the first stage of labor is when a birthing person is between 0 centimeters and 10 centimeters dilated. This type of pain is usually visceral, and it's related to cervical dilatation and effacement. Remember, effacement is that thinning out of that cervical tissue from about 2 centimeters long to like paper thin. Women typically perceive this pain as lower abdominal pain, almost like menstrual type cramps. But it also could be lower back pain and upper leg pain like thigh pain. Any of them are fairly typical. In the second stage of labor, and that's from 10 centimeters dilated until the birth of the newborn, women typically experience somatic type pain. And this is caused by the descent of the fetus, the presenting part, and it's more pressure, pulling, stretching, burning type pain that can lead to lacerations. Those tissues typically are fairly elastic, but when they're stretched too fast or too much, lacerations can occur. In the third stage of labor, that lasts from the birth of the newborn until the delivery of the placenta, that's the third stage. The pain perception is similar to the first stage of labor. It's that visceral pain. Women will typically complain of lower abdominal cramping, and if they complain of anything at all. And then in the fourth stage, it's usually typically related to any type of birth trauma that they experienced. So lacerations or a C-section incision that's usually a burning sensation due to that birth trauma. So as a nurse taking care of a birthing person, we need to assess the patient's desires. We need to have a good idea of what their beliefs are, understand their education of what they know to expect, whether they've attended birthing classes, assessing their social support system. And then we can also demonstrate and assist with different techniques like breathing techniques, imagery, effleurage, which is like a massage type technique, and so forth. And we'll get to that in a later slide. But we also want to promote comfort. We want to connect with that individual and the family, and we want to support them in their decision for their birthing experience. Now in level 1, I'm sure you all learned about different pain scales, and you'll do that when you take care of labor patients and postpartum patients. But there are other things that we can assess for other than a number from that patient. We can look to see whether they have any other assessment characteristics that might indicate that they are having pain. They might be grimacing or groaning, crying. They might complain of nausea and vomiting. And their vital signs might change, so keep an eye on their heart rate and their blood pressure. As I mentioned before, pain assessment is very dependent on culture. Some women have a lot of anxiety, more anxiety as the pain intensity increases, and they may hyperventilate. And that happens when they blow off too much carbon dioxide. If or when that happens, they're going to complain about being lightheaded, dizzy, maybe seeing some sparkles or spots before their eyes. And we would want them to get rid of or to maintain their CO2-O2 balance. If they have a paper bag, if you have a paper bag, you can have them blow into the paper bag and rebreathe that breath to restore that balance. Or if there's no paper bag, you can have that birthing person breathe into their hands so that they're rebreathing what they've exhaled to restore that balance. We also need to see if that birthing person has a birth plan. And I don't know what you're going to hear on the clinical units, but I've heard a lot. The fact is that in the literature, women that have birth plans actually have fewer C-sections. So it's a good thing to have a birth plan. That's a nice communication tool that the patient can use with the nurse, so that the nurse and the provider know what the expectations and what the desires are for the woman, or I'm sorry, for the birthing person. It's really important for the nurse to read through that birth plan so that we can meet those expectations and also identify anything that's not safe in those birth plans, do some education, and then come to an agreement about that item. Birth plans allow the nurse to be an advocate for the patient. So we should be promoting safety as well as the birth experience that the birthing couple wants. All right, the first thing we're going to talk about is non-pharmacologic measures for pain management. And I'm not sure whether you were exposed to the gate control theory yet, but basically, our brains are amazing, and our brains do a lot of stuff all at once. A lot of stuff that we're not aware of all at once. But if we're really intentional, we can only do a couple things at once. And what this gate control theory, in a nutshell, says that if you distract your brain from one thing, it can't spend as much time on the other thing. So we want to distract a woman from that perception of pain by using some other activity. This requires continuous labor support, whether it's from the nurse or from their birth partner. The picture I have up on the slide is a picture of a jacuzzi tub, or hydrotherapy. Hydro is water, therapy. Some birthing units have these jacuzzi tubs, and they really do decrease the perception of pain. So the thought is the woman gets into the jacuzzi tub, that the warm water, she's feeling warm water on her skin, so that takes a little bit, that's another perception. It takes the perception of pain down a little bit. And then she's got the moving water, so that's another little bit more tactile stimulation. She can position the jets to massage areas that are hurting more, so that she's even more distracted. Some birthing units have showers with multiple jets, or handheld sprayers that they can use to direct the water to whatever area they want in order to manage their discomfort. I really do want to talk about ambulation and position changes, but I want to take you back a few million years to the beginning of mankind. Back then, women didn't lay in a bed strapped to a monitor for their entire labor and birth experience. They were up doing things. They were walking, they were gathering crops, they were tending to their children, and a lot of other day-to-day activities. So ambulation not only distracts the woman from that perception of pain, but the movement of walking and changing positions also changes the way the baby is sitting in the pelvis. So all that jostling can help position the baby in the optimum position for labor and birth. So don't discount ambulation and position changes as a good pain management strategy. Babies that are in the optimum position, the mom's labor will be shorter and theoretically less painful. I've never seen acupuncture or acupressure in my practice, but I know it's out there. I just can't speak to it. I mentioned a little bit about focusing and imagery. Again, it's trying to take the birthing person's mind off that perception of pain and giving that person something else to focus on. Therapeutic touch is another technique. Some nurses are certified in therapeutic technique. It has to do with energy fields around human bodies, and what these nurses will do is kind of smooth out that energy field from the pain to the rest of the body. I don't know that much about therapeutic touch. I'm not going to test on it, just know that it's out there. Massage is another technique. You're providing tactile stimulation to distract from all of that pain experience. And then I did mention effleurage, and it's like this light massaging, caressing over the woman's pregnant abdomen. Breathing techniques are generally taught in a prepared childbirth class. There are different breathing techniques for each different stage of labor. And you can teach them while a woman is in labor, and you can assist with those breathing techniques. Other things are aromatherapy. Be careful with aromatherapy, especially around others that have respiratory, some kind of respiratory disease like asthma. Some specific fragrances can cause like an asthma attack, so we'd want to be mindful of that. Music therapy provides auditory stimulation, again, as a distraction technique. And TENS is another mechanism to distract a woman. I don't know whether you know what a TENS is, but it's transcutaneous electronic nerve stimulation. TENS units can be bought on Amazon or over the counter. And they're little sticky adhesive pads that you would place in areas, and then turn the battery pack unit on, and it provides some tactile stimulation, again, as a distractor. Then let's move on to pharmacologic measures. These are probably ones that you're going to see in your clinical experience. So the first type is systemic. We'll also talk about neuraxial or epidural, regional, local anesthetics. And there's been quite a shift over the decades from the passive recipient of labor and labor management to what the woman or the birthing person being an active participant during their labor experience. So we'll talk about systemic analgesia first. Typically, you're going to see IV medication used, typically opioids, could be butorphanol. I've seen it. I'm not sold on it. It's more of a hypnotic. That's how I perceive it works for patients. I do like the efficacy of what I see for Nubain or Nalbuphine. Meperidine or Demerol isn't used anymore. It's fallen out of favor, and I'm not even sure that it's available anymore. The last one in that list is fentanyl or Sublimase, and I see this ordered fairly often for birthing persons for pain management. It's very short-acting opioid, and it's very potent. So what I encourage you to do is look up the dose for fentanyl or Sublimase. The dose is in micrograms, not milligrams. And you've probably seen on the news that it's very easy to overdose on fentanyl because it's so potent. So please, if you receive an order as a nurse for fentanyl, double check the order. It should be in micrograms. And when you are preparing it to give to your patient, make sure that you have the proper dose in micrograms. The next bullet point is ataraxics. Hydroxyzine is Vistaril. I really don't see promethazine or, oh, it just escaped me. I don't see them used. With the exception of hydroxyzine, and we'll get to it on the next slide. Typically, if there's a woman that's having a very, very long latent phase of labor, they'll give it for therapeutic rest. And what it typically does, the woman will, it will relax the woman. She'll be able to get a good night's rest or a good several hours rest, and that will either relax the uterus and she will not have pain anymore, or it'll relax her enough that it'll help her body be in a good established pattern. Promethazine, the brand name is Phenergan. But again, I don't see it used as a analgesic in labor. And then the benzos, I'm not seeing them at all used as pain management in labor. They're typically long acting, and these systemic agents cross the placenta, and you know, we don't want these babies to be, you know, kind of sedated when they're born. The final bullet points on this slide are antiemetics. And earlier we talked about nausea and vomiting as an objective pain assessment. So women may require ondansetron, which is Zofran. You might be giving that. I see that given fairly common in labor, but I haven't seen metoclopramide given. That's Reglan. That's the brand name. On this slide, again, the ataraxics, not seeing them used too terribly often. Really nothing on this slide I see and used as systemic analgesia in labor. The next one here we'll talk about is the epidural, and this is neuraxial or regional anesthesia. An epidural block is placed by an anesthesiologist. They'll typically numb the skin and then insert a large bore needle until they get to the epidural space. It's a hard space to find, but think about your Latin roots. Epi means on top of. Think about epidermis, the top layer of the skin. Epidural is on top of the dura, the covering of that, the spinal, the spinal column there. So they're looking for this epidural space. Once they get there, they take a very small, thin, flexible catheter and insert it into the bore of the metal needle, and they'll pass this catheter into that epidural space. Once it's in that space, they'll withdraw the metal needle, leaving the catheter in place. And through that catheter, then they can infuse medications to cause pain relief, numbness from the upper abdomen down to the feet. Typically, epidural anesthesia is connected to an infusion pump, and there's continuous epidural medication infusing, so the woman has a fairly constant relief of pain. Every once in a while, the anesthesiologist will also order patient-controlled epidural anesthesia, and that's just she gets a button to push so that she gets an extra dose of medication when she needs it. Combined spinal epidural anesthesia is, I haven't seen it done recently, but they'll use a spinal needle to instill some medication in the spinal canal, into the spinal fluid, to give almost complete or almost immediate relief. And then they will place the epidural catheter for that continuous relief. But again, I don't see that typically done terribly often. Intrathecal is spinal anesthesia. You'll see that done for a C-section most often, not for labor. A pudendal block is usually done in the second stage of labor, and it's a regional block that blocks the woman's perineal area. And then local infiltration is just lidocaine that's used either to cut an episiotomy on the woman's perineum or to repair lacerations from the delivery. Last is general anesthesia. Typically, this is only done for emergency C-sections that have to be done in quite a hurry when there's not time to do a spinal anesthesia. But there are also contraindications, like an example would be low platelets. So they wouldn't want to give a woman with low platelets an epidural or a spinal because there could be more complications with bleeding. Typically they give some IV medication and also some inhaled anesthetics, and women need to be intubated. Now, because these are systemic, after the woman is starting to be put to sleep, as soon as she reaches a level of anesthesia, they will start the C-section to try to get that baby out very quickly before those medications reach the baby, or the baby will be sleepy. So if you see a C-section with general anesthesia, it's going to move fast. All right, some terminology on the next few slides. External cephalic version is when a fetus is in a breech presentation. Providers won't let birthing persons deliver breech babies. They just won't. An option is an external cephalic version where the provider will try to flip the baby from breech to vertex head first. But there are some risks involved. Women would come into the hospital, into the labor room, they'd be admitted, they'd have an IV placed just in case there's an emergency and they would need an immediate C-section. We would do some continuous fetal monitoring. We would take vital signs, and we'd also want to note if the woman has a negative blood type, if she had her 28-week ROGAM and it would probably be ordered to give her another dose of RhoGAM after the procedure. And we'll talk about RhoGAM in postpartum, and you'll also be preparing RhoGAM in your med sheets in the coming weeks. Amniotomy is an artificial rupture of membranes, and I wish we were live today. I do have amni hooks that I was going to show you and pass around the class. It looks like a really long crochet hook, and basically the provider, nurses don't do amniotomy, but they're present for that and to assist with that. But it's just like a long crochet hook with a sharper end on it, so it like just nicks the amniotic membranes so the fluid leaks out. There are also amni cots, which are little tiny finger cots with a little tiny hook, sharpish hook on it. Same thing. Nick the membranes are ruptured. We want to document. I hope that you listen to the last lecture and you'll document taco, time, amount, color, and odor. And after a woman has ruptured membranes, whether it's artificial or whether it is spontaneous, the nurse should be taking temperature every 2 hours to monitor for infection. The next thing we'll talk about is cervical ripening. And on the next slide we'll get to is a chart of how we assess cervical ripening. But ways that a woman undergoes cervical ripening, it should typically happen as the result of late pregnancy, but sometimes it doesn't. Ripening just means that the cervix is starting to get soft, it's starting to dilate and efface, and sometimes providers need to do this, or to get that process started before the woman's body does this. They can do it by stripping the membranes, and the provider would do a cervical exam and run their finger around the inside of the cervix. It loosens the amniotic membranes from the surface of the cervix. It also releases prostaglandins. And what prostaglandins do is that they cause uterine contractions, and then the contractions lead to the softening and the ripening of the cervix. There can also be an intracervical catheter. So I'm sure all of you have seen a Foley catheter. I don't know if you've seen a catheter with a 30 milliliter balloon. So the bigger balloon, some providers will insert a Foley catheter up just inside that cervical opening and inflate that Foley balloon to 30 milliliters, and it mechanically softens and then dilates the cervix a couple of centimeters, and also releases those prostaglandins, causing uterine contractions that lead to more ripening. There are also cervical ripening balloons that are made specifically for that purpose, and they kind of look like a Foley, only there are two balloons. One sits on the inside of the cervix and one sits on the outside of the cervix. They're filled with 60 to 80 milliliters of saline and then left in place for up to 12 hours. And again, it helps to put pressure on the cervix, causes the release of the prostaglandins, uterine contraction, softening, ripening. There are also cervical medications, and these are usually prostaglandins. Sound familiar? So a Cervidil is one prostaglandin preparation. It comes in a little tiny tampon-like thing that the provider inserts up next to the cervix. Those prostaglandins leach out, cause uterine contractions, cervical ripening. After 12 hours, it's removed, and then an induction would start. Cytotec is another prostaglandin, misoprostol, that can either be administered orally, or the provider can insert about 25 micrograms up next to the cervix. And sexual intercourse. Semen contains prostaglandins that can lead to uterine contractions and cervical ripening. Also, nipple stimulation causes oxytocin release in the pituitary in the brain. Oxytocin stimulates uterine contractions that can lead to cervical ripening. So the physician, the provider, may suggest to the birthing person to go home and have sexual intercourse or sexual relationships with their partner in order to start that ripening process. Next is labor induction, and that's when we administer a medication called oxytocin. Oxytocin, remember from, it's a naturally occurring hormone. The trade name is Pitocin. We infuse that through an infusion pump, and we connect it to the hub closest to the patient. And then the nurse will titrate the dose of oxytocin according to the uterine contractions, so that there are enough but not too many contractions to cause cervical dilation and effacement, ultimately delivering the newborn. Augmentation of labor is very similar, and we'll talk about, in a few weeks, we'll talk about dystocia, which is like a dysfunctional labor pattern. So augmentation might be ordered for the patient, and they order oxytocin, Pitocin, and it's administered the same way, through an infusion pump, connected to the hub closest to the patient, and then titrated as needed. And there are also alternative and complementary medicine to begin labor. I'm not, as I said, familiar with acupuncture or acupressure for labor induction. However, I've seen the results of castor oil. If you're in a community with Amish or Mennonite, some lay people in those communities recommend that the woman at term take castor oil to stimulate labor. And it does. It's usually very effective, but the side effect is copious amounts of liquid stool. So not the most pleasant birthing experience that I've had to do, but it's very effective. As promised, this is a slide about the Bishop score. And we've already talked about dilation, effacement, and station in the previous lecture. But I want to talk about the position of the cervix. Early in pregnancy, the position of the cervix is actually pointing toward the woman's back. And as the cervix ripens and as labor progresses, that cervix will come around and actually point the right way. So part of the Bishop score is that position of the cervix. Along with is cervical consistency. Early in pregnancy, we want that cervix to be nice and firm because we don't want a baby to come out too soon. But we do want the baby to come out at term. So that cervix, as it ripens, it goes from very firm and it gets to very soft. So the provider would do a cervical exam to assess for these 5 things, and then assess or assign a score based on their assessment. Typically, a cervix that has a score of 8 or more is ripe enough for induction. More birth procedures here. Amnio infusion. It's when the nurse would instill warm saline back up inside the uterus, and this would be done after membranes were ruptured. And typically the only reason to do an amnio infusion is if we're seeing an indication that the cord is being pinched, the umbilical cord is being pinched. This is a procedure that's ordered by the provider, but the nurse can also advocate. They can say, oh, midwife so-and-so, or oh, doctor so-and-so, your patient, Miss Jenny, is having variable decelerations. Do you want to start an amnio infusion? Forceps are metal instruments that are used to assist a birth in the second stage. And a vacuum assisted birth is a suction cup attached to the top of the baby's head, pumped up, creating negative pressure, and the provider will then pull on the baby's head and to help with the delivery. When we meet, I will try to remember to bring all of these fun visual aids so that you at least get an idea of what these things are. All right, for your pre-labor assignment, episiotomy, there are 3 types. An episiotomy is a surgical incision of the perineum to enlarge the vaginal opening. Providers are not cutting episiotomies very often anymore, but if they do, they can do a median or a midline episiotomy, and they go from the bottom of the vagina, the vaginal opening, straight back toward the anus. They don't cut into the anus, they just cut a little bit toward the anus. A mediolateral episiotomy is they go from the bottom of the vaginal opening catty corner, so at like a 60-degree angle. So if there's a laceration, it won't extend into the anus. And then one that I've never seen cut before is a lateral, and that's parallel to the floor. It's painful for the woman, but it's out there. I just haven't had any experience with it. A C-section usually always done for breech presentation. Placenta previa we'll talk more about in the coming weeks, but that's when the placenta covers the inside of the cervix and the baby can't get out. So that's the only way to get that baby out. Fetal distress, active herpes. So if a woman is experiencing an active herpes outbreak, she will need to have a C-section to avoid transmitting herpes to their newborn baby. I have HIV on the slide here because it's in your book, but that is not an indication for C-section, and women with HIV can deliver vaginally. The other 2 terms on this slide, TOLAC, trial of labor after cesarean. If a woman wants to try to have a vaginal birth after she's had a cesarean section, she would be undergoing a TOLAC. If she's successful, she will have had a VBAC, vaginal birth after C-section. And I tell you these things because you may hear these terms on the clinical site. All right, let's move on to stage 2. So the woman the birthing person is now 10 centimeters dilated, and this stage lasts until the birth of the newborn. Depending on the acuity of the birthing person, you'll take her blood pressure and her vital signs between every 5 and 15 minutes. And that's important. Depending on their acuity and their complications, we need to keep a really close eye on their blood pressures and their heart rates, as well as the fetal monitoring strip. We'll want to do some positioning. So women don't always give birth laying flat on their backs in the lithotomy position. We may need to have them push on their side. We can assist them with squatting or hands and knees, but we will be assisting with those positions and position changes. We can help them with breathing and relaxation techniques in between contractions. We want them to take nice deep breaths between contractions to help promote oxygenation of that fetus. Provide comfort measures. So women in second stage labor are working hard. It's labor, it's hard work. They're hot. So some nice comfort measures is to get a basin of ice water and a couple of washcloths, and just wring out those cold wet washcloths, mop her brow, her arms and legs, her chest, to help cool her off. And her birth partner can also do this. We want to make sure that we promote dignity. We want to keep her clean. She is leaking fluids, So it could be clear amniotic fluid, it could be meconium fluid. We'll talk about that in the coming weeks. She could have bloody show, which is mucousy blood. She could be having bowel movements when she's pushing. We want to make sure that we keep her perineal area clean. And then once the baby's born, we can assist with suctioning the newborn, drying, cutting, clamping the cord, whatever that provider would want us to do. Typically for a delivery, there are 2 nurses present, 1 for each patient. The birthing person's nurse will take care of the mom, and the nursery nurse will take care of the baby. I included this slide for that worksheet, that preclinical worksheet that you're working on. These are the cardinal movements. I would encourage you to click on the links there. It gives you a nice idea of how the baby maneuvers the birth canal and what they have to do in order to fit out well. And I also hope that you remember these on the clinical site so that when you get the opportunity to observe a vaginal birth, that you can think about this as you watch the head rotate on the perineum and extend and rotate, and it's a miracle every time. After the baby's born, the patient enters the 3rd stage of labor, and as the nurse, you'll be taking vital signs every 15 minutes. Now this stage is usually fairly short, and typically the placenta delivers within 5 to 10 minutes. If it's more than 30 minutes, that's a retained placenta, and the provider will be ordering other things, and the patient may need to go to the operating room to have it removed mechanically. But anyway, most of the time, the 3rd stage is fairly short. As the nurse, you'll be watching, you'll be assessing your patient, but you'll also be waiting and watching to see what's going on with that placenta. That birthing person might complain of some lower abdominal pain, like cramping, which is something to keep in mind, that the uterus is clamping down. It wants to get rid of that placenta, so she might have a cramp. If you're touching her belly, her uterus might get real firm, might be globular in shape. If you're watching the umbilical cord that's been cut and clamped, it might be lengthening out the woman's vagina. There might be a little gush of blood that would indicate that the placenta is separating from the inside of the uterus. And the woman might complain of some vaginal pressure. Now the placenta is much smaller than the baby, so delivering the placenta really shouldn't hurt because it's so much smaller than the baby. Now that nursery nurse is providing newborn care during this time, and they're doing an initial assessment, TPR on the baby, preparing identification bands so that we don't mix our babies up. And that nursery nurse is also assigning APGAR scores, which we'll talk about in a few minutes. That birthing person's nurse, once that placenta is delivered, the job of that nurse is to administer uterotonic medications. Uterus, tonic is tone, muscle tone. We want that uterus to be firm to help prevent postpartum hemorrhage. So the provider will typically order for the nurse to give a uterotonic medication. 99 times out of 100, it will be oxytocin from the either the induction bag or the augmentation bag. In the 4th stage, after that placenta is delivered, the nurse will provide a recovery care to that birthing person, and typically that 4th stage of labor lasts anywhere from 1 to 24 hours, depending on the birth facility. In the last many years, the different hospitals where I've worked, women are in recovery for 2 hours, and we do Q 15-minute vital signs, temperature, pulse, blood pressure, respiration, we do a temperature once. We don't do it every 15 minutes. But we do it every 15, we do pulse, respiration, and blood pressure every 15 minutes for 2 hours. We want to make sure that this birthing person is stable before we transfer her to a lower level of care, like mom-baby couplet care. We also want to assess her fundus. That fundus is the uterus. We want to make sure that it remains firm. If it's firm, she's less likely to lose more blood or have a postpartum hemorrhage. So we're going to be touching her fundus every 15 minutes. We're going to be looking at her bottom. We want to see the repair of the lacerations or the episiotomy. We want to make sure that everything's okay with that repair. We want to look at her lochia. Lochia is the discharge that a woman has from her vagina after delivery. We want to make sure that it isn't too much. And the way that nurses are doing that today, that you'll see at clinical, is that everything is weighed. All of that stuff that that is used for delivery, and then all of the pads for those 2 hours is put on a scale. And then the dry weights are subtracted, so we know exactly how many milliliters of blood a woman has lost. And this is a newer initiative so that fewer women have postpartum hemorrhages. We want to assess pain and address pain that a woman might have following the delivery. We want to assess urinary output, and we want to make sure that we promote bonding. So initiating that skin-to-skin contact, assisting with lactation if that's how the birthing person wants to nourish their baby. We also want to look at psychosocial adaptation and maternal role attainment. Reuben has 3 stages: taking in, taking hold, and letting go. And I probably will not test on this. But it's really important for you to understand where these birthing people are psychologically. In that taking in phase, those birthing people need to be taken care of. They don't have the capacity for a lot of education. And if they ask a question, we would give little tiny nuggets to answer their question, because that's all they can handle. In the taking hold phase, they're transitioning, so they can handle a little bit more information. And then in that letting go phase is toward the time when they'll be discharged. That's when they're assuming that role change, and they're looking outside of themselves. How can they take care of their family? So I wanted to put this in this lecture, so when you get to clinical and you're prepared to give this whole big teaching, that you don't give it at the wrong time when the patient isn't ready. Look for positive and negative signs of bonding. So once we get to the newborn, we'll talk about bonding a little bit more, but look at the behaviors of that birthing couple and how they interact with that newborn, and listen for cues. Listen for what those parents say about that newborn. Co-parent adaptation, so that the father figure or the birthing partner figure, that's all part of that psychosocial adaptation. Typically you won't see siblings in a delivery. Every once in a while you will, but that's something in your teaching on the postpartum unit that you can incorporate, the inclusion of siblings and how to assess for sibling bonding. These are interventions to promote bonding. So I mentioned skin-to-skin contact. When you're assisting with skin-to-skin contact, please be very mindful of where the baby's nose is. Babies are obligate nose breathers, And we want to make sure that the baby's nose isn't occluded. Some women are very large chested, so we don't want to make sure that that baby's nose is buried in that mom's chest. So to promote safe skin-to-skin bonding, the baby should be positioned parallel, longitudinally to the mom. The head should be on the upper chest, turned to the side so that the airway is not occluded. And then also make sure that skin to skin and covered with a blanket, sometimes a hat. Promoting skin-to-skin contact can lead to early lactation and early lactation success. Rooming in is when the birthing couple has the baby in the room pretty much 24 hours a day so that they learn how to read the newborn's cues in order to provide care. And they do this on the nursing unit so that the nurses can support developing those appropriate care techniques. We want to encourage, support, definitely model appropriate behaviors. And then we want to advocate for what the parents want for their baby. I did include a couple of videos here that show the breast crawl. They're very, very cool. They're not very long. And I encourage you to watch them. Babies, believe it or not, and I was not a believer until I saw these videos, but when babies are put on their mom's abdomen and they're stable, healthy newborns, they're put on their mom's abdomen, they will actually be able to crawl and find the mom's breast without help to be able to suckle and feed all by themselves. Pretty amazing. And then the last slide here, I want you to read through these lists here. There are variables that affect maternal role attainment. And as nurses, we should be trying to key into things that a birthing person or a birth partner might say or do, a behavior they may exhibit that would lead to a negative experience or a positive experience. We have to be very observant and use those cues that we're given in order to be able to promote positive role attainment. So things about the infant, like the appearance, like a lot of people think these babies come out and they are beautiful. And some babies are not beautiful when they come out. So there might be like a disconnect, and their bonding may be impaired because of the physical appearance of their baby. It didn't meet up with their expectations. Also think about babies that are born with anomalies. There may be a problem or some kind of delayed bonding. So these are things that as the nurse you will want to document and then pass on in report to the provider, the pediatrician, and also your coworkers. Responsiveness. Some babies are very responsive. They make eye contact. Others are not. Their temperament, I've seen the whole spectrum. Babies that are very, very peaceful. They're engaged. And then I've seen babies that they have very good lungs and they cry. And some parents really have a problem with that temperament. And then finally, health status of the newborn. Not every baby is stable enough to be with their parents in that mom-baby room. So some babies have to be separated and go to a higher level of care, like a NICU, or even to a tertiary care center for care, and that also can affect maternal role attainment. Well, that is the last slide of this lecture. I appreciate your attention during this lecture. I'm very sorry that this is not live, but at least you'll be able to replay this as you need to. Don't hesitate to reach out and ask questions via email. I'll be checking my email very frequently. I can't wait to see you again on Monday. And we can entertain some questions before we dive into the next lecture. I hope you're all having a great day. Stay safe, and we'll see you soon. The postpartum period begins as soon as the placenta is delivered and lasts for about 6 weeks after delivery. It's a very critical transition period for the woman, the newborn, and the family, both physiologically and psychologically. Another word for postpartum is puerperium, and it's that postpartum period. There are a lot of maternal physiologic and psychological changes that happen with women after they deliver their babies. And it's a big adjustment, not just for the mom and the baby, but for the family as well. We'll talk first about the physiologic changes of the puerperium. The first thing that we should talk about is uterine involution. Now remember, when we were talking about childbirth and delivery, the uterus is where the baby lives for the entire 9 months. And the uterus expels that baby during labor. Then the uterus has to go back to its normal shape and size and position within the mother's body. That's what uterine involution is. The next thing on the list is lochia, and that's the discharge, the vaginal discharge that a woman has after delivery. The lochia changes over time, and we'll be discussing that shortly. There are also endocrine changes. The woman naturally produces oxytocin. It's instrumental in those contractions that result in labor and eventually delivery. So there are endocrine changes, there are decreases in estrogen, progesterone, placental enzymes, and then as the woman returns to normal, ovulation and menstruation begin again. Lots of changes in the urinary system, breast changes, even for formula feeding families, and there are changes in the GI tract. So we'll talk first about ovulation and the return of menstruation, and it's that interplay of hormones, estrogen, progesterone, prolactin, and oxytocin. In non-lactating women, they can expect to begin their menstrual cycle again about 7 to 9 weeks after the birth of their baby. But for lactating women, it really depends on when breastfeeding starts to lessen. So women who have to return to their workforce, and even though they may pump their breasts for milk at 6 weeks when they return to work, just the difference in that that suckling versus pump is it may be enough to stimulate the body to return to a more non-pregnant state. So it could happen anywhere from 2 to 18 months. If women are able to breastfeed their babies very regularly over the course of that time period, it's unlikely that their menses will return, but again, it is very variable. When I'm talking to newly delivered moms and their birthing partners about the return of menses and ovulation, I always include a topic of contraception in here, because women will ovulate before they get their menstrual period. So that means if they're engaging in unprotected sexual intercourse, that means that they may get pregnant before they get their first menstrual cycle after the birth of their baby. We don't know when women ovulate. There are some telltale signs, but we aren't like 100% sure. So I always make sure that I let the mother know and their birthing partner so that they are protected against unplanned pregnancy. So typically in the postpartum period, during the first hour or two, our assessments are every 15 minutes. I know your book says the second hour is every 30 minutes, but I believe both clinical areas that we go to, their assessments are every 15 minutes for that first 2 hours. During the first 24 hours, they're about every 4 hours. And then after 24 hours, they're about every 8 hours. And what's really important in that yellow box that we nurses need to know the normal findings so we can recognize the abnormal findings and then perform our interventions appropriately and inform the provider appropriately. So normally there's a slight temperature elevation during the first 24 hours. If that's very, very common, it should never go above 100.4. And if it does, then we would want to report that either to the primary nurse if you're on the clinical unit or to the provider if you're the primary nurse. That temperature elevation of 100.5 or more may indicate infection. The heart rate during this initial postpartum period may be bradycardia, and that's a normal finding. Respirations are what you know as to be normal for the adult, and the blood pressure should be within the usual range. There are conditions associated with high blood pressure during pregnancy and after pregnancy, and we'll talk about them when we talk about pregnancy complications. We also have a pain goal. We want the mother's pain to be manageable and tolerable. So the goal would be between a 0 and 2 on the pain scale. If the patient reports a pain scale of higher than 2, we would want to offer some pain management medications or non-pharmacological interventions. This is a really important slide, and I would highly recommend that you remember this mnemonic on this slide. This is how you'll do your postpartum assessment when you're on the clinical unit. We associate the postpartum assessment with the word bubble. The first B in the mnemonic stands for breasts. And what we're really looking for is any abnormalities of the breasts. If women are breastfeeding their babies, we want to make sure there's no nipple trauma, like cracked nipples, sore nipples, redness, any kind of bruising that would be associated with like a sucker bite, the baby's not latching onto the proper area of the breast. Normally, we would also assess and ask the woman if she feels like her milk is starting to come in. Typically, the breast will become firm and feel heavy. So we ask the patient those things. The next letter is U, and that stands for uterus. We would assess the height of the fundus in relationship with the mother's umbilicus. We'd also want to assess the firmness. And right after delivery, we want to make sure the fundus is very firm. If the fundus is firm, we know that the uterus is contracting, and it's contracting down and kind of clamping off all of those blood vessels that supplied the placenta. If the uterus is mushy, you'll hear boggy. If it's boggy, then you would want to perform a fundal massage until the uterus is firm again. Along with the height and the firmness, we'd also want to note the placement in the abdomen. Is it midline, or is it deviated to the right or to the left? The second B that we would assess for is bladder. Has the woman emptied her bladder? Has she voided yet, and is she actually emptying her bladder? If you're palpating the woman's fundus, it's it's helpful to also palpate the bladder at the same time. If you should be able to feel the uterus all the way down to the pubis symphysis if the bladder is empty. If there's some urine in the bladder, it'll feel mushy right above the pubic symphysis. If you feel that little mushy area above the pubic symphysis, I usually ask the mother if she feels like she has to go to the bathroom, and usually they'll say yes. I would then let them go to the bathroom and reassess after they void their bladder to make sure that they're truly emptying their bladder. We also want to encourage women to empty their bladders about every 2 hours after they deliver their baby. Sensation in that area is diminished because of all of the different sensations of labor and some swelling and some trauma. So it's a good idea just to educate the delivered mom to empty her bladder every 2 hours. The next B in bubble is bowels, and we would want to listen for bowel sounds, note any distension, ask whether they've moved their bowels since they delivered their baby. And if you have a patient that delivered by cesarean section, if they haven't moved their bowels yet, you would assess them for flatus, which is gas. Ask them if they're passing any flatus rectally. The next letter is L, and that stands for lochia. We'll be monitoring for the amount, the color, and the odor of the lochia. Lochia should not have a foul odor. If there's an unpleasant odor associated with a woman's lochia, that may indicate an infection. Next, we would want to look at her perineum and assess for any episiotomy or laceration repair. We want to assess to make sure there's no perineal hematomas. This can also stand for incision for those women who have had a C-section. So if they don't have an episiotomy and you don't need to look at their perineum because they didn't deliver vaginally, you would assess the incision site instead. If the woman has the surgical dressing still applied to her abdomen, you would leave that in place and just assess the dressing. To assess the dressing, you just make sure that you'd look for any drainage on the dressing. If you find drainage, you would want to circle it and also note the date and time. You'd also note that in the chart and let the provider know, as well as pass that on and report. The next E is extremities. How's their range of motion? Do they have any pain in their extremities? And finally, emotional status. How are they doing? And we're going to be talking about some psychological assessment for that new mom in just a few minutes. This slide shows the proper hand placement for assessing the fundus. You can see that the left hand is at the top of the fundus, and it's hard to see, but the right hand is supporting that lower uterine segment so that if we have to do fundal massage, we don't accidentally invert the uterus. So always remember that when you're doing a fundal assessment, that other hand should be right above the pubic symphysis, supporting the lower uterine segment. Next, we have to talk about uterine involution. And this is a good graphic representation of where you can expect to find the fundus in relationship to the woman's umbilicus based on the days postpartum. We measure this in finger breadths or finger widths in relationship to the umbilicus. So when you're palpating the fundus, you'll measure how many finger widths the top of the fundus is away from the umbilicus. Usually you'll hear the nurses say, oh, her fundus was 1 below you or 2 below you. If you happen to be palpating a woman's uterus fundus and you find that it's a few finger widths above the umbilicus, and deviated to one side or the other, check and make sure that the woman's bladder is empty. More than likely, you'll note bladder distension, and that's usually the cause for the fundus being so high up in the abdomen. I also want to call your attention to after pains. After pains are pretty common in women that have had 2, 3, or more babies, those multiparous patients. They're not very common with primiparous patients, first-time moms. And these after pains are caused by contractions. And we want these patients to have contractions. That's what the uterus does. And the uterus needs to clamp down on all of those blood vessels that supply the placenta so that the patient doesn't hemorrhage. The next bullet point is lochia. And lochia is that discharge from the vagina after delivery. The first day, right after delivery, you can expect to see lochia rubra, and rubra just means red. Right after delivery, it's fairly heavy, like a heavy menstrual period, and I tell patients that their lochia will get lighter in color and amount over the course of 2 to 8 weeks. Immediately following delivery, you'll probably see the nurses weighing all of those pads and associated materials so they can get an accurate measurement of the actual amount of blood loss to monitor for hemorrhage. This is a graphic representation of how we describe the amount of lochia. So we talked about accurate measurement of blood loss. When we weigh the peripads, we would put that peripad with lochia in the on the scale, and then we would subtract the dry weight. And 1 gram is roughly equivalent to 1 milliliter of blood loss. Then the pictures above, from left to right, you can see a scant amount of lochia, a light amount, a moderate amount, and then a heavy amount. An excessive amount would be a pad that's saturated in 15 minutes or less. And we do want to teach our moms that if they're saturating a pad in an hour or less when they go home, they need to either come back into the hospital or call their provider. These are some other reproductive system adaptations, and this is a look at what the cervix looks like before the first pregnancy and then after pregnancy. It goes from being more of a hole to more like a jagged slit. The vagina eventually will, that lining, the mucosa will thicken and the rugae will return, although muscle tone is not fully restored. And we should be teaching the women to do Kegel exercises to help strengthen those weakened perineal muscles. It also helps with bladder control. When you're doing your assessment on the woman's perineum, also you'll want to turn her on her side and look for hemorrhoids. It's also easier to see the repair when the woman's on her side, and then you would just spread those butt cheeks. When you're looking at the perineum, if the woman has any kind of a repair, either lacerations or episiotomy, or if you're assessing an incision, you can remember REDA, which stands for redness, edema, ecchymosis, drainage, and approximation. And then you can document that. For the perineum, you want to teach her how to take care of those stitches and also how to take care of the lochia. And you'll do that by teaching her pericare with a peri bottle. It's just like a little 8-ounce squirt bottle that you'll teach her to fill with warm tap water, and then after she uses the toilet, she'll just spray that warm tap water over her perineum from front to back. After that, she can pat her perineum dry with toilet tissue, And immediately after delivery, an ice pack like an ice peri pad feels nice on that perineal tissue. Lined up with witch hazel pads and using benzocaine spray, I bet you'll see dermaplast used on your units. We can also teach the use of a sitz bath, which is shown on this slide. A sitz bath is just a pan of water that you fill with warm tap water, and then you also fill a reservoir bag up with warm tap water. Thread the tubing through the appropriate hole in that pan of water, and then the woman can sit on that and have that warm water bathe her bottom with the reservoir bag. She can sit in that nice warm water until she feels comfortable, or until the water starts to run a little bit cool, and then just have her dry off and apply her peri products. Lactation is the secretion of milk by the breasts, and at birth the woman's breasts have colostrum in them. Mature milk appears on the 3rd or 4th day after childbirth. For moms that have already had lactated in the past, their milk may come in sooner. And for moms that have never had produced milk in the past, their milk may be a little bit longer in coming in. And again, this is the result of hormonal interaction. We already talked on that bubble assessment, things that we would look for. We would want to actually look at the infant latch to see how they're doing in order to determine whether they need some extra assistance, or perhaps a visit from the lactation consultant. It's helpful to understand that breastfeeding causes a release of oxytocin, and oxytocin causes contractions of the uterus. So you can tell these lactating moms that they can expect to have some cramps when they breastfeed, and this is the reason why. For those moms that choose to formula feed, we need to provide information about lactation suppression. Lactation suppression just means that we don't want the milk to come in. We would tell these moms that they should be wearing a very supportive bra, a tight supportive bra. They should avoid stimulation of their breasts. Avoid standing in the shower facing the warm water and allowing that warm water to run down their breasts. That will stimulate milk production. We should tell them that they can use ice packs to help prevent some milk to come in. And every woman has engorgement after they deliver. It's that full feeling, the breasts get very full, very firm. We would want to teach these women that they should put ice on their breasts to help their milk stop coming in. They can use analgesia if they want to for any kind of discomfort, and the use of cabbage leaves also helps with that engorgement. Engorgement typically only lasts about 24 hours, so it's relatively short. Just a good picture of a nurse helping with lactation, and the graphic shows the different hormones related to lactation. I just talked of engorgement. For the lactating woman, engorgement's relieved by frequent emptying through breastfeeding. We would want to encourage them to take a warm shower to help with engorgement. It also helps with the letdown reflex. There are cardiovascular adaptations, and the important things on this slide are the blood volume and cardiac output decrease. The woman does experience some blood loss due to delivery, and that you can see changes in their CBC immediately after delivery. But we also see that is very common diuresis, so a lot of urinary output following delivery, as well as diaphoresis or sweating. And that just has to do with getting rid of the extra volume that the woman had in their circulatory system to adapt to the pregnancy. WBCs can remain elevated for up to a week, and coagulation factors will remain elevated in the postpartum period. This predisposes women to blood clots during the postpartum period. So we want to prevent blood clots by establishing early ambulation. Their pulse rate and their blood pressure should return to normal. And this is just the explanation for that postpartum diuresis that I explained on the previous slide. Some nursing interventions associated with the cardiovascular system is to make sure that you promote adequate oral intake of fluids. Many times women are NPO in labor and pre-op for their C-section, so they may be a little bit dehydrated. We want to promote that adequate oral intake of fluids, especially for lactating women. They need to take those fluids in order to make enough milk. We want to promote early ambulation, and some women will require TED hose. SCDs, especially for operative women, C-section women, you'll see SCDs used in the operating room and then until they're ambulatory. And that's to prevent deep vein thrombosis and pulmonary embolism. The GI system quickly returns to normal because the uterus isn't full of a fetus. There's not any extra pressure on those structures. They may have decreased bowel sounds for the first few days, especially for C-section moms. And constipation is common because they're afraid to strain. You can put their fears at ease. They're not going to pop their stitches, and they should have a normal bowel movement within the first few days. We want to promote good nutrition. This is a time where the body does have to heal, and it needs good nutrition in order to heal the body. Breastfeeding women should be taking in about 500 extra calories per day in order to sustain their milk. And that's not on top of the extra calories associated with pregnancy, but they need that 500 extra calories on top of what they normally should have. Something else to note on this slide, that for patients that experience that 3rd and 4th degree laceration that enter the anal sphincter and the rectal mucosa, that there should not be anything per rectum for those patients. So no enemas, no suppositories. We talked a little bit about urinary system adaptations, and we do need to promote and teach that they should go to the and empty their bladder about every 2 hours. Normally women will put out a vast amount of urine the first couple of days postpartum, and that is just getting rid of that extra blood volume, the plasma volume associated with the late stages of pregnancy. We want to make sure that we monitor for that first void postpartum, and it should be within the first 6 to 8 hours. If the mother becomes distended and cannot empty her bladder on her own, we may need to perform a straight catheter. Musculoskeletal system has undergone a lot of adaptation during the pregnancy. One of the things that the body does, the placenta produces a hormone called relaxin. that relaxes the joints so that the pelvic outlet is a little bit more adaptable to accommodate the fetal head. This makes, the relaxin makes the other joints in the woman's body looser, which puts them at an increased fall risk. However, within 6 to 8 weeks postpartum, those joints return to their pregnant state, except for the women's feet, and a woman can expect to have an increase in their shoe size about a half a size. There's a decreased abdominal muscle tone after birth, and we can teach them specific exercises to return to normal. However, we don't want them to be doing this immediately after birth. We would give them instructions on these muscle exercises, abdominal muscle exercises to take home. I mentioned the Kegel exercises. Immediately after delivery, the woman is at an increase for falls because there's a lot of stuff going on, a lot of fluid shifts, fatigue, maybe they've had an epidural, their sensation may not have returned. So the chart that's included on this slide is for your information. You don't have to memorize the chart, but it is the just an assessment that we would want to do before we would get a woman out of bed to decrease the risk of falls. We want to make sure that we check the blood pressure first. Are they within normal limits? We're going to get them up slowly, allow them to sit and dangle for a few minutes before we stand them up. And if they ever get lightheaded or dizzy, we would not get them up and ambulate them. Regarding the immune system, we'd want to review the woman's rubella titers. If the woman is non-immune or equivocal, we would want to make sure that a MMR, measles, mumps, and rubella, is ordered for that woman prior to discharge. Rubella is an infection that a woman can have, and if she has rubella within the first 3 months of pregnancy, it can result in pregnancy loss or profound anomalies. We'd also want to look at the woman's RH factor, and if the mother is negative, has a negative RH factor, and the baby has a positive RH factor, we'd want to make sure RhoGAM is ordered for the woman. RhoGAM is prophylactic and given to a woman who has an RH positive baby so that there's no isoimmunization that happens in the next pregnancy. Also with varicella, we would assess and administer vaccine before discharge if a woman hasn't had chickenpox. And then also the Tdap vaccine is recommended for the adults of the household, primarily to prevent pertussis in the newborn. As we progress in the course, you will learn about some integumentary system changes during pregnancy. Some of those changes include some hyperpigmentation. This will fade over the course of the next 2 to 6 weeks. Stretch marks that are common on the woman's abdomen or breasts or buttocks, upper arms, it just depends. Those angry red marks will eventually fade to silvery lines, but they never completely go away. And then we talked about diaphoresis or sweating. That's very common for about a week postpartum. For the respiratory system, this also returns to normal within 1 to 3 weeks after birth, and the anatomic changes that happen during pregnancy, they also return to normal fairly quickly. We already talked about the endocrine system, so I'm not going to spend any more time here. And there are psychosocial adaptation. When we talked about the newborn, we talked about bonding. We need to allow the woman and the birthing partner to verbalize feelings about the pregnancy, the delivery, and also the newborn. We should be assessing the emotional status and encouraging skin-to-skin contact, rooming in, bonding with that newborn. We need to document our findings and provide referrals as needed. For that mom that underwent a C-section, we need to assess the incision and teach how to take care of that incision, including teaching signs and symptoms of infection. Usually, sutures will dissolve within 7 days, and generally, women can shower within 24 hours of their C-section delivery, and that surgical dressing is usually removed and not reapplied. We would teach the woman that she should use soapy water to clean her incision, rinse it, and then pat it dry and leave it open to the air. We should be encouraging surgical patients to turn and move and cough and deep breathe, and generally they should be using an incentive spirometer to prevent pneumonia or atelectasis. We'd want to listen for bowel sounds for the return of peristalsis. Initiate early ambulation. We also would want to provide some comfort measures, and providing an abdominal binder or teaching the person to splint the incision helps with that discomfort of that incision. They shouldn't be doing any heavy lifting, no more than their infant, for the first 6 weeks, and they should limit their stair climbing if at all possible. If needed, we would tell them that they would follow up within about 7 to 10 days if they need to for suture or staple removal, and then to follow up for their 6-week postpartum checkup. These are all a list of things that we should be teaching over the course of their postpartum stay. And it's really challenging due to that short nature of the postpartum stay. Now, we talked in an earlier lecture about Rubin's stages of postpartum role attainment. These are hard to do because the woman doesn't move into that final stage until they're getting close to going home, or they are at home. But providing that just-in-time teaching as the patient asks about pericare and as we perform those interventions is a good way to try to get all of these teachings in before discharge. This slide shows the postpartum danger signs, and you need to be very familiar with these danger signs for the exam. Anytime the patient has a fever, foul-smelling lochia or discharge from their incision, blood clots, headaches, visual changes, calf pain, any of these are postpartum warning symptoms that they need to report to their provider right away. Some challenges facing families after discharge. We're a very mobile society, so there might not be any family that are around or close by to provide role modeling and support for the new mother.